Today we're going to be covering NG tube. So the first thing we want to do is verify your provider's order. So I've received an order for my patient Gladys Stevens, date of birth 216XX, to insert a nasogastric tube now. The physician wants me to connect it to low intermittent suction and that a KUB, or kidneys, ureter, and bladder x-ray, will be done post-insertion to confirm that it's in the right place. Okay? Now my patient Gladys has a small bowel obstruction, meaning none of the gastric juices are going through. Okay? So she, because of that, is experiencing nausea and vomiting. So this NG tube will actually help her eliminate a lot of that nausea, and it should stop the vomiting. Now, the provider ordered it to low intermittent suction, meaning the suction will go on and off intermittently. Because our gastric juices are so rich in electrolytes, especially potassium and sodium, we don't want to remove that too quickly or we can cause a shift in electrolytes. So we typically always want to do it to low intermittent suction. Okay, so I've checked the provider's order, and before I go in the room, I like to gather my supplies. So the first thing that I'm going to need is the tube itself, okay? Similar to a Foley catheter, an NG tube comes in French, okay? So opposite of our needle sizes is the French. So the smaller the French, the smaller the diameter of the tube. The larger the French, the larger the tube. So typically for an adult patient, a 14 to a 16 French will be appropriate. For a child, pediatric, a 10 to 12 French could be used. So I've got the appropriate sized NG tube, okay? We're gonna want some lubricating KY jelly, and that allows it to go in a lot easier. We also are gonna want an irrigation kit, and with that comes a piston syringe that we can use to both flush and to aspirate gastric juices within the tube, okay? We also will get pH paper because after we insert it, before we get that x-ray, we're able to pull back some of the gastric juices and check the pH. And what that does is it tells us that we're in the stomach and not into the respiratory tract. Okay, I should have gloves and hand sanitizer in the room. I will need some tape, okay? So we're going to anchor the tube to the nose to ensure that it doesn't accidentally come out. Now, some hospitals have special securing devices that has a clamp that holds onto the tube. Not all hospitals have that, but tape is what you're going to be used for checkoffs, okay? So we have all of our supplies. The next thing that I want to do is go into the room and explain to the patient and start getting ready to put in the tube. Okay, so let's go ahead and do that. Okay, knock, knock. Perform hand hygiene. Hi, Miss Gladys. It's Megan. I'm back. Before I start, can you please tell me your name and your birthday? And she says Gladys Stevens, 216XX. Miss Gladys, do you have any allergies at all? And she says just to morphine. Okay. And are you having any pain anywhere today? And she says she's not in pain, but she's feeling really nauseous and she just vomited. Okay, so that's probably why we're putting in this tube. So, Miss Gladys, your provider ordered for me to insert a nasogastric tube. And what that is, it's a small tube that we're going to be placing from your nose down to your stomach. And it's going to suction out a lot of those fluids in your stomach that are making you feel very nauseated and are making you vomit. Okay? Do you have any questions for me about the procedure? And she says no. And I'll also ask her, has she ever had any nasal surgeries or a deviated septum? Because we want to know that before we enter into the nasal cavity just to make sure. Okay, and she said no, she doesn't. All right, so at this point, I'm going to go ahead and I'm going to provide privacy if I haven't done so already. Close the curtain. I've already done my hand hygiene. I do want to get all my supplies set up. So typically first, you'll want to get your tape ready. So what I like to do is take a long piece of tape, and this is the one that I'm going to be using to anchor it to the nose. So what you do is take your tape and kind of rip it in half, but not the whole way, okay? You want to leave about an inch at the top that you're going to put on the nose, and these two pieces of tape are going to wrap around the tube to hold it in place. So I'm going to leave that right there on my bedside table, and I'm going to take a second piece of tape that I'm going to be using to mark the tube to make sure that I've put it into the right length. Okay, that'll make more sense in a second. So I've just got a small piece of tape there, okay? All right, I've got my lubricant. If I want to, I can open that up at this point and have it ready to go. I like to bring in a towel for the patient too and place it across their chest. Sometimes people cough, sneeze a little bit with this. It can be uncomfortable. So a lot of times I will bring in a towel and just place it across their chest. So I can do that right now. I've got a checks pad and that'll work just fine. All right, so she's all ready to go. I'm going to go ahead and put on my gloves. And the next thing I'm going to do is check the patency of her nares to decide which nostril that I want to use for this tube. So a couple of different ways that you can use to do this. I typically will use a pen light where I can shine in both nostrils and look to see, does it look open and patent? You can also ask them to occlude a nostril and breathe in and out. Okay, well, it's spring down here in Georgia and I've got some allergies. So my right nostril is sounding better. Okay, so that's what you would do to your patient to determine which of the two would work better. Now, positioning for putting in an NG tube, you'll want to position the patient in high Fowlers. So at least, typically I do at least like 70 to 90 degrees. It makes it easier for that tube passing and going down. Okay, so now I've got her prepared and I'm all ready. What I want to do next is measure the tube so that it's going in. We want to make sure that it's not too far down in the stomach because it can coil and come back up, but we also don't want to make sure that it's not far enough into the stomach where it could be up in the esophagus. So the way that you do this is you take out your tube. Remember, this is clean and not sterile. We're dealing with the GI tract, which is not a sterile system, not like the respiratory or the urinary system. So we're at this point, we just need to be clean. You don't need to be sterile, okay? So what you're going to do is take your tube, and on your patient, you're going to measure from the tip of their nose. Can you see? Kind of hard to see. So from the tip of their nose to the earlobe, and then down to the xiphoid process, okay? And your xiphoid process is right under the breastbone, okay? So this is the area on me that I would do it. So that's obviously what you would do to your patient, just so you can see what I'm doing. So now with this, some of these tubes have numbers where you can just remember. This one does not. It's got a little marker, but I'm going to take that small piece of tape, remember that I left out earlier, and I'm going to put it on around right where I know that I need to stop, and that'll tell me that it's in the stomach, okay? Now with this tip of the NG tube, I'm going to go ahead and get my lubricant, and I'm going to put lots of lubricant on there because it does make it pass a lot easier for your patient. Okay, so I've got it nice and lubricated. Okay, so make life easier for you, I'm going to show you on your model that we're going to be using. Okay, so before I begin, typically I want them to blow their nose, get their nose ready to make sure there's nothing in it, and they're actually going to tip their head back when you begin. So we'll ask them to tip their head back, and you'll go ahead and say, take a deep breath and start inserting your tube. Now, when you get to the back of the nose, you'll kind of feel a little bit of resistance. At that point, I want you to stop and then have the patient tip their head down now, and you're going to try to advance, asking them to swallow. So we'll say swallow, 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 and just keep advancing it all the way to that piece of tape where remember we marked where the xiphoid process was, okay? Now, some patients, the doctor might allow them to take a sip of water while we're telling them to swallow. With this patient, we don't want to do that. She's got a small bowel obstruction, and if she's drinking the water, it's not going to go anywhere. It's going to make that nausea worse. So you can just tell them swallow. Sometimes they will allow you to have a little sip of water as they're swallowing it because it allows that tube to pass a little bit more easily. Okay, so once I've got it to where I want it, where I know it's at the right spot, we are going to temporarily anchor it to make sure that we're in the right spot. Now, I don't want to use that hospital device with the clamp yet, because if we're not in the right spot, we might need to put it in or pull it out a little bit more, and it can be uncomfortable for the patient, okay? So what I'm going to do is just take that piece of tape from earlier, and I put it on the patient's nose, and I'm going to kind of lightly secure it around the tube, not permanently, just because I'm not completely sure that I'm in the right spot yet. Remember, the two things that we do to verify placement are checking the pH, okay? And then the other thing, obviously, is the gold standard, which is the radiographic, that KUB, that x-ray that tells us with certainty it's in the stomach, okay? So now that I have it in the patient, what you're going to do is take your piston syringe, this big syringe, okay? And I'm going to attach it to the end of the tube, okay? One thing I forgot to mention is that if you accidentally put it down the nose and into the respiratory tract, the patient will start coughing, be very uncomfortable. You'll see them tearing from their eyes. Their pulse ox can drop. So if there's any inkling that you might be in the lungs and not the stomach, immediately remove the tube. You don't want to be including the respiratory tract at all, okay? And that is something that can happen with this procedure. So always be watching for that you're in the respiratory tract. And again, you'll see coughing, you'll see gagging. They can turn blue if it's remained in. So if there's any thought that you might be in it, immediately remove it. Now, my patient handled this well, didn't have any of those issues, so I'm pretty sure that I'm in the stomach. Okay, so now I've attached my piston syringe, and I'm going to pull back a little bit of fluid. Now, I don't need much, only about maybe 2 to 3 mLs of that gastric fluid to check the pH. So what I'm going to do is pull it back. Typically, your gastric secretions are grassy green in color. They might be clear yellow, but typically they're grassy green, okay? If they're brown, that typically indicates blood. Now, remember earlier I told you you want to have a med cup and your pH testing paper, okay? So what I do is I keep my pH paper in the cup, and then remember I've got that 2 cc's, 2 to 3 mLs of gastric fluid. I'm going to push that onto the paper, okay? Now that I've done that, I can compare it over here, and I'm looking for a pH of less than 5. Typically, your gastric contents are between 4 and 5. Greater than 6 tells us they're in the lungs. So if this turns blue, immediately take out the tube. But typically, you would know before this point. Okay? So the pH of this was 4, okay? And it looks like gastric contents, okay? So now what we're going to do is hook this up to our suction, okay? And then we're going to order radiology to come up to check that KUB to ensure that we're in the stomach. Okay? So now that I know that my pH is correct, I can anchor this a little bit better. So I did a temporary fix just to make sure. So now I'm going to really make sure that it's taped well and securely taped to my patient so that it's not going to come out. It's a little bit traumatic doing this. We don't want to re-put this back in multiple times. Typically, we like to just put it in once, secure it, and have it in. Okay, now at this point I might have some gastric contents, so I can go ahead, take off my gloves, do some hand hygiene, and I'm going to reassess my patient. Okay, so what I'm going to do is, let her know, Gladys, I know this was uncomfortable. You handled it very well. Are you starting to feel any better? Now, this would pretty much prevent her from vomiting. So we can check to see now, is your nausea any better? And ask her, does she have any pain associated with that? Is there anything else that I can get for you today? And she says, no, she's doing okay. All right. So we'll do all our typical stuff where I'm going to lower the bed, lock it. If she's uncomfortable, I can decrease the head so she's not sitting so straight up. Okay. I've got her call light for her, and then she said she doesn't need anything else right now, so I'll come back and check on her. Now, the things that I want to document on this are the size of the tube, what the secretions, the gastric secretions look like, what color are they, what is the consistency, and then the amount that came out, okay? So typically we do I&Os at the end of our shift. So you would document how much came out with initially putting it in and hooking it up to suction. Okay, thank you.